Hi, my name is Faye Hines, and welcome to my Institutional Review Board proposal presentation on the association of vitamin D status in preterm infants with respiratory syncytial virus. The purpose of this study is to assess vitamin D levels in preterm infants admitted to the neonatal intensive care unit and the effect of supplementation until discharge or 40 weeks post-menstrual age on immunologic and pulmonary function. What is of particular interest for this study is the emerging evidence that supports the role of vitamin D in immune functioning, including the modulation of innate and adaptive immune responses. Research shows that vitamin D inhibits B and T cell proliferation. It also affects T cell maturation and the induction of T regulatory cells. The effect of vitamin D on immune cells results in the increased production of anti-inflammatory cytokines and the decreased production of inflammatory cytokines. This is of particular importance in neonatal medicine, as premature babies are especially vulnerable to severe life-threatening infections. Respiratory syncytial virus is the most significant respiratory pathogen in infants and is the primary cause of sickness and rehospitalization in preterm infants, with preterm infants accounting for 1/3 of all RSV-related hospitalizations. This leads to the following research question. Is vitamin D supplementation of 800 international units per day versus 400 international units per day more effective for the prevention of RSV in enterally fed preterm infants between 24 and 34 weeks gestation? It's hypothesized that vitamin D supplementation of 800 international units per day versus 400 international units per day will result in fewer incidences of RSV in enterally fed preterm infants born between 24 and 34 weeks gestation. This study aims to further investigate the safety, efficacy, and quantity of vitamin D supplementation and its impact on immunologic and pulmonary function, specifically the likelihood of RSV infection in preterm infants admitted to the neonatal intensive care unit. There is a growing body of epidemiological evidence linking vitamin D deficiency to immune dysregulation and severe respiratory tract infection, highlighting the crucial yet less well-known role of vitamin D in protective immunity. Gind and colleagues examined the association between serum 25-hydroxyvitamin D concentration and upper respiratory tract infection in 18,833 individuals of at least 12 years of age between 1988 and 1994. They concluded that serum 25-hydroxyvitamin D concentration was negatively correlated with upper respiratory tract infection. Helfrich and colleagues studied 599,535 children enrolled in the military health system and found that prematurity is an independent risk factor of RSV infection and hospitalization in children of less than 24 months of age. Onwenemy and colleagues evaluated the vitamin D status of 94 preterm infants in the NICU from birth until hospital discharge, and vitamin D status was associated with respiratory morbidity. Similarly, Backstrom and colleagues noted an increased frequency of respiratory distress syndrome and an increased requirement for assisted ventilation in preterm infants receiving vitamin D supplementation of less than 400 international units per day compared to those receiving supplementation of greater than 960 international units per day. Despite this growing body of evidence linking vitamin D to better outcomes for premature babies, there is still a lack of consensus regarding the optimal dosage of vitamin D supplementation in this population of infants. The American Academy of Pediatrics recommends 200 to 400 international units per day of vitamin D3 supplementation for preterm infants, while the European Society of Gastroenterology, Hepatology, and Nutrition recommends 800 to 1,000 international units per day of vitamin D supplementation for preterm infants. Pinto and colleagues concluded that nutritional supplementation of vitamin D of an average of 643 international units per day resulted in a significant decrease in the proportion of preterm infants that were vitamin D deficient at discharge. McCarthy and colleagues assessed the serum 25-hydroxy vitamin D levels of 274 preterm, very low birth weight infants and concluded that a daily dose of greater than 400 international units per day vitamin D achieved the target vitamin D level in the majority of the infants studied. However, the study also noted that further research needs to be conducted to determine the exact dose to safely meet target levels of vitamin D while obviating toxicity. Preterm infants born at Mount Sinai Hospital in Toronto, Ontario, Canada, between 24 and 34 weeks gestation and admitted to the NICU within 48 hours of birth will be considered for the study. Caregivers must be willing to provide written informed consent within 1 week of admission, and infants recruited for the study must also achieve full enteral feeds within 2 weeks postnatally. Infants will be excluded if they have major congenital malformations, severe life-threatening illness requiring admission to a higher level NICU, multiple gestation pregnancies. They will also be excluded if they do not achieve full enteral feeds within 2 weeks after birth. And infants that have a serum 25-hydroxy vitamin D concentration of less than 75 nanomoles per liter or greater than 125 nanomoles per liter at any time after 4 weeks of age will be immediately excluded from the study, as this is indicative of inappropriate vitamin D supplementation. A power analysis was performed using G-Power software to ensure a 95% confidence level. The value of alpha was set at 0.05 and a Cohen's d value of 0.5 to reflect a medium effect size was used. An a priori t-test involving the difference between two independent means was performed, which resulted in a minimum sample size of 210 individuals or 105 individuals per intervention group. Participating infants will be randomly assigned by computer-generated randomization to receive either 400 international units or 800 international units of vitamin D3 daily. A blood sample will be obtained immediately prior to the initiation of enteral vitamin D supplementation, and additional blood specimens will be obtained at 4 weeks of age and at 40 weeks postmenstrual age or at discharge. The study drug used for vitamin D3 supplementation will be vitamin D Enfamil D-Visol, which contains 800 international units of vitamin D3 per milliliter. For exclusively breastfed infants assigned to receive 400 international units of vitamin D supplementation per day, 0.5 milliliters of the drug will be administered once daily, either directly to the infant or mixed with expressed breast milk. Similarly, for exclusively breastfed infants assigned to receive 800 international units per day of vitamin D3 supplementation, 1 milliliter of the drug will be administered to the infant either directly or mixed with expressed breast milk once daily. For infants receiving human milk fortifier or preterm formula, the study drug will be reduced as per the vitamin D content of the human milk fortifier or the preterm formula to ensure that supplementation does not exceed either 400 international units daily or 800 international units daily, depending on the intervention group. Participants will be monitored for RSV. A nasal swab will be performed immediately upon the presentation of any RSV-related symptoms as per usual protocol in the NICU by the attending nurse. These symptoms may include fever, dyspnea, difficulty feeding, difficulty breathing, among other symptoms. Confidentiality must be maintained in accordance with the Personal Health Information Protection Act. This is Ontario legislation, seeing as the study will take place in Ontario, Canada. Mount Sinai Hospital maintains all patient information in electronic medical records, or EMRs, and follows the standards set out in PHIPAA. The research team will be granted access only to the EMRs of those patients involved in the study and only for the duration of the study. Upon initiation of the study, each patient will receive a randomly assigned arbitrary identification number, and this will eliminate the need for personal identifiers. A private meeting will be arranged with parents or guardians of eligible infants, the head researcher, and the attending neonatologist upon admission to the NICU. The primary purpose of this meeting will be to provide information regarding the study to the parents or legal guardians of prospective subjects and to assess whether there is any interest in study participation. It will be the researcher's responsibility to ensure that parents or guardians understand the role of their infant in the research. And the parents or guardians of prospective infants may decide immediately to participate in the study, at which time they will sign an informed consent. They may also take additional time to consider their decision. In this circumstance, a follow-up meeting will be arranged for 1 week's time. Reasonably foreseeable risk includes inadequate vitamin D supplementation, excessive vitamin D supplementation, potential distress as a result of blood specimen collection. Various procedural safeguards have been implemented to minimize these risks as much as possible, including blood specimen collection that aligns with hospital protocol. So this will minimize any undue stress imposed on the infant as a result of blood drawing, as well as provide adequate monitoring of deficiency or toxicity before the clinical manifestation of deficiency or toxicity. A potential immediate benefit to subject participants includes the attenuation of vitamin D deficiency. Data will be reported in aggregate. Descriptive statistics will be used to analyze continuous data, and students' t-test will be used to analyze normally distributed continuous variables. Categorical data will be expressed as proportions, and categorical variables will be analyzed using the chi-square test or Fisher's exact test. Statistical analysis will be performed using the latest version of SPSS. This study is significant because it builds on the current body of evidence purporting the putative role of vitamin D in immunologic and pulmonary function in preterm infants, and the findings will decrease the uncertainty surrounding the requirement, quantity, and duration of vitamin D supplementation in preterm infants between 24 and 34 weeks gestation to achieve optimal outcomes and decrease the incidence of RSV infection. Some limitations include maternal dietary intake. This will not be documented throughout the study. However, for those infants that are exclusively breastfed, it is well known that minimal amounts of vitamin D are transferred via breast milk, so this should impact their serum 25-hydroxy vitamin D concentrations only negligibly at most. Also, this study does not account for maternal vitamin D status at the time of birth, and research shows that neonatal vitamin D stores are 50 to 70% dependent on maternal vitamin D status. The study will provide data on the vitamin D status of preterm infants based on acceptable supplemental dosage quantities of vitamin D3 for preterm infants and standard NICU nutritional practices. Findings will be generalizable to infants admitted to other NICUs within North America and can be used to inform future intervention studies to further assess the effect of optimizing vitamin D status in preterm infants on short-term and long-term clinical outcomes. The findings of this study will be instrumental in explicating the association between vitamin D status and the incidence of RSV infection. However, it will be one of few studies to investigate this relationship among premature infants. Therefore, more larger studies should be conducted to investigate the relationship between vitamin D status and the incidence of RSV infection in preterm infants. That concludes my presentation. Thank you so much for listening.